What about four-drug regimens, Cristina? Where do you think daratumumab and elotuzumab might end up in our practice? There is, maybe you could start by telling the audience about the trial that will be presented here, looking at daratumumab in the frontline setting, if you're comfortable with that.
Yes, well, the trial, the four drugs trial that is going to be presented at ASH is the Alcyon, right, in non-transplant eligible, where the daratumumab is added to the melphalan-prednisone, bortezomib, Velcade, and there is a phase 3 randomized, so patient are on the 4 drugs versus the 3 drugs. And it looks like the daratumumab impacted on the depth of response and the PFS. I mean, it's too early to say. And one of the critique we were talking earlier, unfortunately, the NPV arm, the therapy was discontinued. After 8 cycles, while on the daratumumab there was a continuation of therapy that probably impacted on the depth of response, continuation, and PFS.
So this is a very important study.
Yes.
Just spend a minute on it here. Bob, your reaction to this VMP with continuous daratumumab versus VMP alone. Do you think this will get FDA approval and be part of our standard of care, or tell us how you interpret this?
I agree. The data are very positive, not unexpected, but VMP is not very popular here in the U.S. There is an abstract from Andrzej Jakubowiak looking at KRD with DARA. It's a single-arm study.
That's the first time I heard anybody pronounce his name perfectly. So there's Polish heritage there, but go ahead.
Exactly, yeah. I've got a little bit of background there. But they had virtually a 100% response rate and a very high VGPR or better rate. I think it was 80 to 90%. So it's certainly an active regimen. It would take a randomized study to try to see if it's better than KRD or VRD. I actually like Hari's approach, and I've done that on a couple of patients where we typically start high risk and even standard risk people on KRD. But if we don't see a PR after 1 cycle, we think about adding daratumumab, and especially if you hit a plateau fairly early, and you're not at a complete remission, I think adding a 4th drug would be reasonable, and that's one way we could maybe reduce the financial toxicity so that we're not giving the 4 drugs to everybody up front.
Thoughts on this important phase 3 trial, Noopur?
So again, I think most people have captured the limitations of the study, that you have a standard of care arm which has limited duration treatment. And I think what we've learned over the last several years now is continuous therapy should be the way to go in older as well as younger patients. So with those caveats, I think everybody's covered everything on the study.
So you think we'll be using daratumumab up front soon?
I do, may not necessarily be with the VMP combination. The Maya study will be coming out, and the readout for that is RD.
What is the Maya study for the audience?
Maya study is lenalidomide dexamethasone with daratumumab compared to Lendex alone, and we hope to see that data probably late next year.
Harry?
Yeah, just as Noopur said, then there's the ongoing Griffin study in the United States where daratumumab with RVD, the most popular triplet here, is with DARA added is compared. So.
It seems somewhat inevitable to me that daratumumab, a 4-drug cocktail, will be part. It is going to be financially difficult, and any solutions there? Any thoughts? You talked about you talked about continuous therapy. What about giving shorter durations of therapy?
One way of looking at it, and because we have the diagnostic tools in place, and we haven't really gotten into MRD just as yet, Keith, but with this MRD tool, one can imagine that if you use 4 drugs, you're going to really deepen responses with depth of response. If you get to that MRD negative state, you may be able to actually stop treatment after a fixed duration.